Thank you and welcome for joining us this evening for this Australian and New Zealand Head and Neck Cancer Society webinar. Tonight, we're discussing a topic close to my heart, advanced practice and innovation by dietitians, improving care and outcomes for people with head and neck cancer. So my name's Jenelle Loeliger and I'm your chair this evening. I am the Manager of Nutrition and Speech Pathology at Peter MacCallum Cancer Centre in Melbourne. And we have a really fantastic lineup for you tonight. We'll hear from two very experienced dietitians, so Associate Professor Merran Findlay, and her presentation will be followed by Jane Stewart. And then in addition to Merran and Jane, we've got three multidisciplinary colleagues joining us. So Dr. Tsien, Sarah Davies and Rhys Hughes, who will join us for a panel discussion. So the ANZ Head and Neck Cancer Society acknowledges the traditional owners of the land on which we gather today and the many lands on which we undertake our work. So for me, I'm on the lands of the Wurundjeri people of the Kulin Nation. And we recognise their continuing connection to these lands, water and culture, and pay our respects to their elders past, present and emerging. So just a little bit of housekeeping. So tonight, we're really keen for you to submit any questions you might have as we progress through this webinar. And the aim will be to address these once we get to our multidisciplinary panel towards the end of the webinar. So if you can use the Q&A section, which you should be able to find, depending on what device you're at the bottom or the top of your screen. So before we get underway with our presentations, to help us tailor our discussion within this webinar, we'd love you to complete a couple of really quick polls for us. So I'm just going to run the first poll. So you can see here, would love you to tell us what discipline you're from. And I'm going to apologise in advance if your discipline is not listed there as a category. Please feel free to put your answer in the other category, and happy to take comments in the chat if you'd like to say who you're from, which discipline you might be from. I'm just going to give you a couple more minutes. Sorry, a couple more moments. All right, I'm going to end the poll. And I'm just showing you now what our audience is made up of. We've got quite a lot of dietitians joining us, so welcome. We've got a couple of speech pathologists, a physiotherapist and a radiation oncologist. And we do have someone in the other category, so thank you. Our second poll. We'd love you to tell us about whether you have any of the following in your cancer setting. So you can choose multiple answers. Just going to give you a moment. Brilliant. All right, I think we've got quite a few people who have polled. So as you can see on your screen, we've got lots of dietitians who work in your head and neck cancer team. That's great. We've got a number of dietitian advanced practice roles, which is wonderful to see, and we'll hear more about that tonight. Quite a lot of dietitian-led clinics and co-located clinics. Fantastic. So let's move on to our first speaker. So I'd like to introduce Clinical Associate Professor Merran Findlay. And Merran is a recognised leader in head and neck cancer nutrition. She's a clinician researcher and an advanced accredited practicing dietitian, and her research focuses on the impact of cancer-related malnutrition and sarcopenia on patient outcomes and health services. Merran's research includes leading the development and implementation of evidence-based guidelines and has been recognised with a number of awards, most recently the 2022 Dietitians Australia Joan Woodhill Research Excellence Doctoral Prize. Welcome, Merran.
Thanks, Jenelle. I'm just going to take a moment to share my screen. And we will be away. Okay, so thanks, Jenelle, and welcome to everyone joining us this evening. And I'd like to thank the Society for the opportunity to bring this webinar on advanced practice and innovation by dietitians. And I have the pleasure of giving a research update on some of the fabulous innovations and research that's being led by Australian dietitians. Maybe just a few scene setting slides in case there are some newcomers to the field. That really we do know that the types of disease and the nature of the treatments, they're often multimodal and for a prolonged period, bring about profound nutrition impact symptoms that really impact on an individual's well-being in almost every aspect. So this brings us to the really big and very real problem of cancer-related malnutrition and a related condition called sarcopenia. They're both prevalent in patients with head and neck cancer, and they're poor prognostic factors. They're independently associated with a range of poorer outcomes, including reduced survival. And when we consider sarcopenia or low muscle mass, is something that may actually be occult, and so is malnutrition. These conditions may not be immediately evident. They may be present regardless of overall body weight. And if we consider that a lot of water-soluble drugs, including platinum-based chemotherapies, which are often used in head and neck cancer treatments, are distributed largely through lean tissue, it's not surprising that people with low muscle mass will run into trouble and are predisposed to chemotherapy dose-limiting toxicities. So I guess that's the key take-home message here is that irrespective of body weight, patients may be at risk of poor outcomes. So I thought about how to present this information, and I thought I would walk you through the evidence to practice pipeline and how we use knowledge that's generated through new and innovation research, how we synthesize it into clinical guidelines, and what we do with those in terms of implementing them into practice. It's not to imply that that process is linear. I think it's anything but. We tend to be at various stages in that pipeline at the same point in time. But there's lots of innovation happening, and really what we're aiming to do here is improve not just nutrition-related outcomes, but cancer outcomes overall. It contributes to a broad range of clinical and cost and patient-centered outcomes. So I tend to say whether you're a dietitian or other supportive care clinician, whether you're an oncologist, a surgeon, and a healthcare administrator, we all should really be caring about the nutritional status of the patients we're providing care to. I'm really pleased to make mention of a number of leading dietitians who have either completed or are undertaking PhDs in head and neck cancer nutrition. And it's really thanks to the fabulous leadership of Professor Judy Bauer. She has supervised many of us. I think on this page alone, we have something like 25 top-tier journal peer-reviewed publications, really covering the breadth of all the aspects of head and neck cancer nutrition care, with Dr. Teresa Brown's enormous contribution in nutrition support. Dr. Joanne Hyatt's recently completed PhDs, really nice qualitative work around experience-based co-design that looks at the information and resource needs from patients and carers' perspectives. And Anna Edwards is currently doing some work in HPV positive disease, which we know is a subgroup of often younger patients that will make a valuable contribution to future practice. So myself and Belinda Vangelov have been working in the space of CT-defined sarcopenia over recent years. And I wanted to start there when we're talking about generation of new evidence. So let's dive in and start there, since it's really much a hot topic in cancer literature overall. If you're new to this field, just a little quick orientation that the gold standard for what do you call it, body composition analysis at the tissue organ level is at the level of the third lumbar vertebrae. So that's an axial view at L3. And from here, using specialized software, we can tag the different tissue types. So we have the red is the skeletal muscle, and the other three colors are the different types of adipose tissue. From there, we can normalize the surface area for height, yielding a skeletal muscle index. And as you can see in the figure on the right, that the muscularity isn't really dictated by body mass. We can have two patients with identical body mass index where their muscularity varies enormously, and vice versa. So I guess in an era of individualized medicine, we actually still do a lot that's weight-based in cancer care. So body surface area for chemotherapy dosing, BMI, it actually tells us very little about the metabolic capacity of the people that we're treating. And I guess the explosion in this field has really happened because these scans are taken in routine cancer care. So in addition to the diagnostic and staging information, it actually yields a plethora of information about the individual and should you care to look. So it interested me enough to undertake a PhD in this field, and over a series of studies, I was able to really take a bit more of a deep dive. When I started, there were only literally a handful of patients in papers in head and neck cancer. There is now more than 100. We did learn that CT-defined sarcopenia and malnutrition are both poor prognostic factors. But interestingly, malnutrition, as measured by the patient-generated subjective global assessment, which is our simple bedside measure that's recommended in all of our evidence-based guidelines, was actually a more powerful prognostic indicator than the CT-defined sarcopenia. And it was independently associated with reduced overall survival. What we learn in terms of practice, and when you look into this literature, sarcopenia is often reported as a binary proposition. Are they sarcopenic, yes or no? But in reality, human body composition is far more complex. And this particular diagram shows that sarcopenia occurs in isolation very little of the time. It occurs in combination with other body composition features. And what we really need is a much larger data set to be able to start to unpick what that means in terms of risk. And I would see the future would hold being able to answer that in a way that we may have a way to identify people with high risk phenotypes that we can act and intervene much sooner. What we do know is that these conditions are both independent risk factors for poor outcomes, but there's no single tool to detect both. So it is important to screen, assess and treat both conditions. The risk of reduced overall survival relating to malnutrition had a hazard ratio of about 3 in my PhD studies. But when we looked at a meta-analysis of pooled results from over 19 studies and over 5,000 patients, the hazard ratio for the risk of reduced overall survival was close to 2. We do see some associations with risk of chemotherapy dose-limiting toxicities and unplanned admissions, but the grade certainty of evidence for those studies is low at the moment, and that's mainly due to imprecision, and that's due to the lower numbers of patients in those reported studies where those outcomes are included. But I do suspect we'll see that improve, or the certainty of evidence improve over time. My colleague, Belinda Vangelov, has recently completed her PhD answering one of the sort of more challenging questions in this field. If you're looking in the head and neck cancer specific literature, it's worth being aware that it's a little bit of a wild west with the methods that people are applying in body composition analysis. The level of L3 is not universally available in some centres. The scanning imaging technology doesn't go that low, and people may only have access to other landmarks higher up in the thoracic and cervical regions. It doesn't necessarily mean that it has been validated. So that was Belinda's challenge. What she's been able to do is demonstrate that sarcopenia is often misclassified if not using L3. And that you can see in the image on the right there that there's some positional challenges, particularly if doing repeated measures over time, that those measures are less reliable. And she's also developed a prediction equation that can transform C3 measures to L3 if you do not have L3 available. It certainly has better agreement and specificity than a previously published study, but it's really a rapidly evolving area and one to sort of keep on top of the rigor that's required to do it accurately. And in doing so, I can segue nicely to just make a mention of the body composition analysis by CT course that Judy Bauer and I are offering again. We've done this face-to-face in previous years, but have teamed up again with Professor Vicky Barakos and Dr. Lisa Martin, our colleagues in Edmonton, who are leaders in this field. And we hope to be able to offer that course in the latter part of this year as an online offering. And Judy, I know, will be very happy to hear from people interested in undertaking further study in order to include that in their own research. So moving along the evidence to practice pipeline, looking at evidence synthesis, I hope many of you joining are already aware of our evidence-based guidelines that we have published. They're a decade old now, they've had their 10th birthday, internationally endorsed, and it's an ongoing process for a small but talented group of dietitians keeping those updated. And in this past year or so, we've benefited from some long lockdowns and some dedicated UQ Masters students doing some systematic reviews to update some of our key clinical questions from the guidelines. Essentially, the evidence remains consistent and strong for our optimal frequency of dietetic counselling and intervention and the timing of it. Obviously, earlier is best. But where the literature does fall down is in the TORS literature. We had 8 RCTs included in that systematic review, and unfortunately not a single one of them has actually included nutritional status as an outcome measure. What it would be really great to see for those of you working in that space to be involved in those surgical studies as part of the research team so that you can help guide selection of appropriate endpoints and interpretation of the key findings, because the nutritional status will absolutely influence the surgical complications and outcomes. So I'll talk a little bit more about the other guidelines in these next slides. If you're working in the surgical space, enhanced recovery after surgery is probably not new to you, but I was fortunate enough to be invited to be involved in the development of the original head and neck cancer protocol through the ERAS Society. And you can see that it's a multifaceted, multidimensional, multidisciplinary, and actually, in fact, a very large and complex intervention that takes really careful planning and implementation techniques in order to make sure it's done successfully and sustainably. In blue, you can see highlighted the nutrition care elements, and each one of those can actually be quite challenging to implement in isolation. So I was interested to see, it's probably 5 or so years since that paper was published, that there's now about 14 separate studies reporting implementation of the ERAS protocol in head and neck cancer populations. And a recent couple of meta-analysis suggesting that there's a positive influence on outcomes such as reduced length of stay and ICU length of stay and opioid requirements. But there's still a gap in terms of knowledge about longitudinal outcomes and the patient's experience. We've recently had a dietitian colleague working with us to do a scoping review about how well the nutrition care elements are reported in those studies, and spoiler alert, not very well. It is a little bit patchy, particularly given things like minimising perioperative fasting in large hospitals, a notoriously challenging thing to do. So I think it would be very nice to see that reported better in these studies. And I am aware that there's a number of centres around the country actively implementing ERAS in head and neck cancer, and that may also have a prehabilitation component to it. So I'll be super excited to see the results of that work, and I hope it's going to be shared at some of the upcoming conferences. While not head and neck cancer specific, we would really like to draw your attention to a significant piece of work that's been led by Associate Professor Nicole Kish from Deakin University and the rest of us in the COSA nutrition group. The position statement on cancer-related malnutrition and sarcopenia, you can see a really nice infographic there that highlights the screening, assessment and treatment recommendations. That it is really very much a multidisciplinary undertaking. We talk a lot in cancer care about how important nutrition is as everyone's business, not just the dietitians. We need our exercise experts at the table. We need our oncologists, surgeons, nursing staff and all our allied health colleagues in order to ensure that those systems and processes are in place. So I'm really pleased to say in a very hot off the press update that we've recently secured some additional funding that will now allow us to move forward with developing an implementation toolkit, and that work will be led by Jenelle Loeliger, and that's something we look forward to sharing with you, because it will ultimately support, no matter where you're working, support you implementing those recommendations in practice. So we move towards the implementation end of the evidence to practice pipeline, and that's really where many of us spend a large majority of our time. It seems like it should be simple, but we work in large and complex organisations where the simplest things can often be incredibly challenging, and there are quite convoluted processes that we need to navigate in order to do that successfully. So some really nice examples. The dietitian-led clinic published by Nicole Kish and the Peter Mac team. This is a few years ago, but it's looking at dietitians taking the lead in decisions around nutrition support and timing of feeding tube insertion. And it's really pleasing to see that dietitian-led clinic led to a reduction in nutrition-related hospital admissions, unplanned nasogastric tube insertions, and a reduction in the need for radiation oncology review at the 2-week follow-up time point. And it also improved patients' transition to oral diet following radiotherapy. And I think this is a really nice example of value-based healthcare, where we are able to deliver outcomes of importance to patients at the most responsible use of the health service dollar. And as an added bonus, a really highly skilled and expert clinician gets to operate at the top of their license. So it's really, rewarding and benefit in many ways. And while Dr. Ben Britton isn't a dietitian, he's probably honorary dietitian by now. He's done fabulous work in leading the EAT study as a really great example of a cluster RCT in implementing evidence-based guidelines into practice. And he worked with dietitians to upskill them in delivering a psychological intervention. And that was driven by cognitive behavioural therapy and motivational interviewing techniques to deliver the principles of the Eat to Live program. And pleasingly, that's delivered a whole range of improvements in terms of nutritional status and psycho-oncology scores into the lower depression scores and greater quality of life, and fewer interruptions to radiotherapy. So this is a really nice example of how multidisciplinary designing research the way care is delivered can have enormous benefits. I'm also aware that there's in the pipeline some updates, longitudinal data that should be quite exciting to hear since that study finished, what has happened in the longer term for those patients that participated. So moving on, having been involved in developing clinical guidelines, I really wanted them to be followed in my own centre. They were to some degree, but not as good as what they could or should have been. So this led to an NHMRC TRIP fellowship, and we were able to take the time to understand from patients, their families, and also clinicians' perspectives about their experiences of both receiving and delivering evidence-based care. And in doing that, with that consultation, we came up with an evidence-based model of care with 2 key interventions. There was a supportive care-led pre-treatment clinic and a nutrition care dashboard that was integrated into the weekly MDT discussions. And what we found is that patients who had received the new model of care were more likely to receive care in alignment with the evidence-based guidelines, so the improved nutrition care process measures. They were also more likely to receive treatment as planned. They were less likely to require hospital admission. And of course, at about $30,000 per unplanned admission, the costs avoided equated to approximately $15 per every dollar that was invested in delivering the model of care. So we can see that evidence-based models of care are feasible, but they also deliver benefits at individual, team, and system levels. So it's a decade from implementation, or from evidence sort of to practice. I like to call it a 10-year overnight success, but really what we've been able to do is follow that evidence to practice pipeline in the 10-year post development of our guidelines. We undertook a second survey of national practice. We were able, in terms of impact, to determine that dietitians were using the guidelines to guide practice. They were also using them as to support business cases for workforce resourcing, and which is actually, what's required in order to deliver evidence-based care. And we have since participated in an international multi-centre study and about adherence to best practice guidelines, and it's pleasing to see that Australian dietitians are doing extremely well. We can't let this session go without making mention of the fabulous work being led by Jenelle and the Peter Mac team. The co-design of information and resources is a phenomenal undertaking to ensure that these fabulous information and resources are available that meet the needs of both patients, families and clinicians. If you're not aware of them, please check that out on the Peter Mac website, and please use them in your routine practice. You will find them invaluable. And lastly, a few comments on future directions. Well, look, there's a lot of opportunity to close some of those evidence practice gaps. Sorry, I should start with closing the evidence gaps. I would really like to see malnutrition and sarcopenia related measures included in clinical trials. If we're in an era of individualised medicine, we really do need to understand how they influence the current treatments that are provided. I know Teresa Brown's doing some fabulous work on taste, which is a terribly distressing symptom that patients experience. Looking at oral microbiome and also some TORS research. Myself, I am in my current fellowships and work with UNSW and data scientists, and my Sydney Health partners work with some health economists, looking at value-based models of care and also looking at the real-world evidence obtainable through better use of data analytics and nutrition care dashboards, which builds on the previous work. So I believe Teresa and I are going to be giving some updates at the upcoming Head and Neck Society meeting in the Hunter Valley. So I hope you can join us for that. And really the bread and butter, we have so much fabulous evidence. We have so much fabulous synthesis in our guidelines. The mainstay of where we should be directing our energies is in those innovative models of care to ensure that people are getting access to the care that they need at the right time and in the right setting. Going to wind up just leaving you with a couple of resources. Some of those might be a little bit state specific, but if you're looking for implementation science, co-design sorts of work, check out your local health service and university precincts. They will almost certainly have something similar. And really just to acknowledge that the leadership in the dietetics research around Australia is influencing practice and policy both nationally and internationally, which is fantastic to see. I'm going to finish there by acknowledging the people that inspire the research and also those that have guided, supervised and supported, and also the funders. So I'll finish there and hand over back to you, Jenelle. Thank you.
Thank you, Merran. Brilliant. The 10-year overnight success. I love it. I can't wait to see what the next 10 years brings. I will just remind you while I am just sharing my screen, please pop any questions that you might have for Merran in the Q&A, and we will look to address those once our panel convenes. So next up is our next speaker, Jane Stewart. So Jane is an accredited practicing dietitian and has worked as a clinical dietitian in a range of settings in both Australia and the UK for over 20 years. We're lucky enough to have Jane in our clinical lead dietitian role at Peter Mac, and she leads the home enteral nutrition and PEG service. So she's been credentialed as a PEG dietitian since 2010, and this has been across 2 major health services. She's been actively involved in the Victorian Cancer Malnutrition Collaborative Program of work since 2016, and also contributed to the development and dissemination of COSA's position statement on cancer-related malnutrition and sarcopenia. Welcome, Jane.
Thanks, Jenelle. I'm just going to share my screen. So good evening, everyone, and thanks for your introduction, Jenelle. So today I'm going to talk to you about dietitian-led gastrostomy management. Peter Mac is Australia's only public health service solely dedicated to caring for people affected by cancer. It also has the largest head and neck service in Victoria, where patients undergo complex high nutrition risk treatment with intense dietitian involvement throughout their journey. Peter Mac has a well-established multidisciplinary PEG clinic with approximately 100 PEG or gastrostomy tubes inserted per year. In 2020-21, we had approximately or exactly 426 patients on our HEN program, with 82% of these patients having a history of head and neck cancer. So to give you an idea of the volume of patients that we have coming through, that equates to about 220 patients that we manage per month. Home enteral nutrition, or HEN, refers to the provision of nutrition support orally or via a feeding tube in the home environment. Individuals requiring HEN, particularly via a feeding tube, often have complex healthcare needs and require specialist multidisciplinary care. In 2020, a benchmarking audit of HEN services across Australia and New Zealand was completed, and the audit identified 107 HEN services across Australia and New Zealand, caring for more than 7,000 HEN patients. Approximately 2/3 of these patients were adult, with the remaining 1/3 being paediatric. 82% of adult patients had a gastrostomy in situ, and head and neck cancer was the top reason for HEN patients. Of note, only a quarter of HEN services reported patients could present to their PEG service rather than ED in case of tube dislodgement. So advanced practice dietitian roles therefore represent a massive opportunity to reduce ED admissions and costs to the health system. So tube feeding is common in head and neck cancer, and this can be pre and post surgery or pre, during and post chemoradiotherapy. The COSA guidelines on the nutritional management of head and neck cancer recommend prophylactic enteral feeding should be considered for patients who have T4 or hypopharyngeal tumours undergoing concurrent chemoradiotherapy. Other patient groups should be considered on an individual basis dependent on other clinical factors, such as tumour site, staging, the effect of multimodality treatments, radiotherapy treatment fields and dose, type of surgical procedure, nutritional status, dysphagia, and social supports. Prophylactic tube feeding compared to reactive tube feeding demonstrates improved nutrition outcomes and quality of life and clinical outcomes. So before we talk about advanced scope of practice, it's important that we understand scope of practice. So defining the scope of practice involves delineating the extent of an allied health practitioner's clinical practice within a particular organisation based on the individual's credentials, competence, performance, and professional suitability, and the needs and capability of the organisation with which they work to support the practitioner's scope of clinical practice. And a profession's full scope of practice incorporates the full spectrum of roles, functions, responsibilities, activities, and decision-making capacity that individuals within that profession are educated, competent, and authorised to perform. Some functions within the scope of practice of any profession may be shared with other professions or other individual groups. So advanced scope of practice should fall within the recognised scope of practice for the profession and involves tasks traditionally performed by other professions such as doctors, nurses, or other allied health clinicians. Advanced scope roles require additional training, significant clinical experience, and competency achievement. Dietitians Australia recommends that advanced or extended scope should be permitted where it allows more efficient management and care of the patient and decreases the number of visits or transactions in the patient journey. For dietitians, this could include taking blood glucose levels, adjusting insulin dosage, inserting or changing feeding tubes, or prescribing parenteral nutrition. Advanced practice roles require a formal credentialing process, which typically involves a component of theoretical training, such as competency packages, observation of tasks, and practical skill development before sign-off of competence. A mechanism for maintaining competence and annual recredentialing should also be put into place. So what is the dietitian's involvement with head and neck cancer patients? So in the hospital setting, dietitians are well equipped to work to advance scope of practice. Enteral feeding is core business for clinical dietitians, and they typically have more interaction with patients than most other health professions. Traditionally, the dietitian's scope of clinical practice encompasses education regarding enteral nutrition care, prescribing formula type and regime, monitoring of feed tolerance and tube or stoma site, troubleshooting and coordination of PEG removal. So dietitians are well placed to remove and change gastrostomy tubes to provide streamlined, coordinated patient care. The advanced practice gastrostomy dietitian role has been evolving and growing over the past 18 years. In 2005, Alfred Health was the first site in Australia to commence a PEG credentialing program. Over the next 10 years, the UK and the US also began implementing advanced practice gastrostomy management roles. In 2015, the Victorian Department of Health supported 6 health services to develop advanced practice dietitian roles in gastrostomy management. It was about this time that Queensland and New South Wales also started developing advanced practice roles, and both Queensland and New South Wales now have PEG credentialed dietitians at a number of health services. To note, there is no standard approach to the advanced practice gastrostomy role across Australia. The scope of these roles vary from site to site, with some dietitians credentialed just for gastrostomy care or site management, such as for things like checking balloon volumes and stoma care, while others are credentialed for just external traction removal or balloon changes, and others are then credentialed to remove or change tubes. So the Peter Mac PEG service consists of 3 PEG dietitians, 2 PEG nurses who are stomal therapists, and a PEG registrar with oversight from an upper GI surgeon. We have a weekly PEG clinic attended by 2 PEG dietitians, a PEG nurse and a PEG registrar, where we educate and consent patients who are referred for PEG insertion, as well as removing and changing PEGs and stoma site management. We also have an emergency PEG service where we see patients with dislodged tubes or urgent tube and stoma management issues. The Peter Mac PEG dietitians triage PEG clinic referrals and manage the PEG waitlist, educate patients regarding the need for PEG, PEG management and the HEN program prior to PEG consent, provide PEG troubleshooting advice such as changing Y ports, adding clamps, positioning of the tube, etc. We also provide advice regarding changing the tube type. So we found that the use of low profile tubes can significantly improve patients' quality of life, particularly for those who are requiring long-term tube feeding. They remove PEG tubes, both external traction and balloon tubes, and change tubes, so both long balloon tubes and low profile tubes, and respond to urgent PEG-related issues. An evaluation of the Peter Mac PEG service was conducted in 2018, 3 years after the introduction of the advanced practice gastrostomy role. Overall, patients were satisfied with their clinic visit, including information provided to them, their waiting time and the flow of appointments. And 60% of patients reported they only saw 1 clinician in PEG clinic. And this was prior to the introduction of this role. This was more likely 2 to 3 clinicians per visit. Interviews with clinicians were also conducted. The interviews revealed the PEG dietitian role is a positive addition to the PEG team. PEG clinic works well as a multidisciplinary clinic with co-located rooms. PEG dietitians enjoyed the role. It was nice. They commented that it was nice to see patients at the final stage of their treatment journey. There was a reduced requirement for the PEG registrar and PEG nurse in PEG clinic. The time from referral to PEG insertion was felt to be appropriate, and there were no adverse events recorded. So the recommendations from this review included aiming for more than 2 credentialed dietitians, which would assist with leave and succession planning. And we now have 3 PEG credentialed dietitians, although we are about to lose 1 on mat leave. So there's a constant revolving door. It was also felt that the natural progression was to have dietitians change PEGs as well. So previously we just did external tractions, and we now have 3 of us trained to change both long balloon tubes and low profile tubes. It would be helpful to have a PEG dietitian available to see PEGs outside of PEG clinic, and we now offer a 5-day PEG service for emergencies. And that the final recommendation was that we should improve referral triage and booking processes, and these have largely been resolved with the introduction of our new electronic medical record. So what are the benefits of the advanced practice PEG dietitian role? Well, the benefits to the patient include improved access to safe and timely care, with reduced wait times for PEG change removal and reduced waiting times in clinic. Streamlined care with reduced number of appointments for patients, increased flexibility for access to care. For example, being able to access PEG changes outside of PEG clinic, particularly for rural patients. The benefits for staff include improved continuity of care, increased job satisfaction for dietitians with better opportunities for career progression. The model provides strengthened multidisciplinary care of PEG patients. And last, the benefits to the health service include it's a patient-centred model of care, timely access to care at reduced cost, reduced emergency department and hospital presentations, and it allows medical and nursing staff to be available for more complex patients or tasks. What are the enablers for a successful advanced practice PEG program? Well, this includes executive support, strong multidisciplinary collaboration, a clear governance structure, local processes including a local allied health credentialing committee and existing advanced practice roles within the health network, a large enough dietetic workforce to maintain a credentialed workforce, and adequate patient numbers to maintain confidence and competence. So where to next? The US have developed a competency model for training dietitians to place nasogastric and small bowel feeding tubes. Insertion of post-pyloric feeding tubes using electromagnetically guided techniques has been common practice in the US for about 2 decades, and dietitians in Adelaide have recently begun inserting post-pyloric feeding tubes. In Queensland, one regional hospital has begun credentialing dietitians to insert nasogastric tubes. The model of care was found to be safe, to improve patient flow and access to services, and was welcomed by clinicians. It will be interesting to see if this advanced scope of practice model of care will become the norm. Other areas of exploration for dietetic advanced practice roles include CT body composition measurement and advanced practice gastroenterology dietitians who currently work at a number of Victorian hospitals with the aim to reduce gastro waiting lists. Thanks for your time today. I'll pass you over to Jenelle.
Thank you, Jane. Such a great overview of one example of an advanced practice role that dietitians can take on. I am now going to welcome our panel. So joining Jane and Merran is Dr. Tsien, who's a radiation oncologist from Peter Mac in Melbourne. We've got Sarah Davies, who's a nurse practitioner and head and neck cancer at Chris O'Brien Lifehouse in New South Wales, and Reese Hughes, a senior speech pathologist from Peter Mac in Victoria. So Jane, if you could stop sharing, and we'll try and get everyone's faces up on the screen. Wonderful. Now, we've got a couple of questions in the Q&A, and I'm going to throw to those first, just to make sure that we answer these burning questions. So Jane, because you've just spoken, I'm going to throw it to you first. So there's a question from Laura. So, hi Jane, at what point in the journey would you consider a change to low profile tubes for head and neck patients?
Yeah, we generally like them to have a mature stoma tract. So usually it will be after they've had their initial tube removed, which is usually sort of 12 months to 18 months of having their initial gastrostomy tube. We may at that point decide if they're likely to have a long-term tube put in a low profile then. But probably in reality, most patients generally would have a couple of long balloon tubes before we change to a low profile tube.
Great, thanks Jane. And while we're on the topic of tubes, there's just a question that's popped in. So either this could be Jane or Merran, perhaps jump in, or actually anyone else from our panel. Are you aware of any tools or flowcharts that are available to decide on a patient getting prophylactic feeding tubes in chemoradiation patients? Who'd like to take this one?
Look, I'm happy to jump in and kick it off, but I think it's the $64 million question that everyone's always wanted, this perfect algorithm. If patient has this, then do that. What we know from the evidence-based guidelines, and I think it's question 19, because we've lived that for a decade now, that really a lot of it relates to clinical judgment and based on several factors, and it's relating to the patient themselves, what pre-morbid conditions they have, what's their nutritional status at baseline, and then things about the diagnosis, the treatment plan, all of those things I think are factored in. There will certainly be some high risk combinations of things that mean that people will be more likely to require a prophylactic feeding tube. And they might be things like more advanced stage disease or combined treatment in terms of chemoradiotherapy to high-risk tumour sites, and particularly around the oropharyngeal, hypopharyngeal, nasopharynx. They're all going to cop quite a big dose, and I won't speak too much in that with the radiation oncologist in the room, but perhaps he would like to comment further. but yeah, really that perfect algorithm doesn't exist, but taking on board all of the key elements around treatment, patient are a really great place to start, and then monitoring. That's the vital piece of information, is that if they don't have a prophylactic tube and you've missed that window, then there are other plans in nutrition support you can action as they go throughout care.
I think that's an excellent answer, Merran. We have some set guidelines, I guess, for the black and white simple ones, and they are obviously the big T4 tumours, patients that are presented with weight loss already, they're already having significant dysphagia, you know that they're going to run into trouble. And then there are some more nuanced things that as a doctor, when you're talking to them and you're explaining that they'll probably need a feeding tube, they may, when you're examining them, have an incredible gag reflex, and you just realise later on down the track, we're not going to be able to get a nasogastric tube down, they're going to gag, it's not going to be tolerated, and then you can put them down the prophylactic pathway early.
Great. Would anyone else like to add? Jane, Sarah, or Reese? No, I think that was a wonderful answer. Thanks, Tsien and Merran. And Merran, just through to you before we go to one of our other questions that we want to explore. So Merran, how do you convince or manage patients that are obese that are happy with treatment-related weight loss, knowing that this is not a positive thing? So despite having perhaps given them information about sarcopenia and the risks and complications of that.
It's a good question. Thanks, Aoife. I don't, again, know that we have the magic answer, but where I think it really does matter as a starting point is consistency in messaging amongst the multidisciplinary team. We do have often patients expressing that they have been advised 10% weight loss is common. It also doesn't mean it's a target. It also doesn't mean because it's common that we shouldn't be avoiding it or aiming to avoid it or minimize it. And then I guess there's that reinforcing from other staff if we're giving the same message that it's linking back to strength and function, which are concepts that patients perhaps are more able to understand than something as vague and nebulous as sarcopenia. What does that mean? And I think there's some further work to be done. I've often wondered how we can do that better. I would be very interested in exploring that with patients, and even seeing some of our images when you can see the pre and post, how much muscle people have lost, that sometimes seeing something visual might have an impact. I think there might be a little bit more work to be done in exploring how that might be optimized. I know having Sarah in the room that she often conveys that same message consistently to patients as well. And even maybe using things like grip strength, where patients can actually see that number changing. That may in itself be somewhat of a motivator. But yeah, they're my initial thoughts, but happy to hear others.
Yeah, I do think consistent messaging as well, especially from our medical colleagues, our radiation oncologists, medical oncologists, because I do hear, not often, but occasionally, the patients will say, oh no, the doctor said, whether or not it's true, the doctor said, no, it's okay, you're already overweight, so it doesn't matter if you lose 10% of your body weight. And we know it's not okay. So I think consistent messaging is really, key.
Thanks, Sarah. I think that really does emphasise, like Merran had said earlier, about that nutrition is everyone's problem. It's not just one person that needs to be giving this one message. It's across the entire MDT. I guess in terms of tonight, we're talking about successful models of care and some examples of some innovation going on in this space in the care of head and neck cancer patients. I guess I'm keen to ask and sort of whip around everyone in regards to, well, what are the key components? I guess in addition to the ones that Merran you've explored and Jane you've touched on, I guess some of those key components, and also, if you want to throw in there any tips for strategies, I guess knowing that this is really where some gaps exist. We've got some great evidence that's available to us, but how do we put it into practice in our health settings, in our hospitals, and outside of our hospitals as well? So I'm keen to hear about those key components or any key strategies that supports optimal nutrition care. Merran, I'm going to throw to you quickly to just chuck a few things out there, and then we might go to Reese after that.
Thanks, Jenelle. I think there's probably three key things that come to mind off the top of my head. Having the appropriate structure of your services, not just, that dietitians are core members of the MDT, but also the physical co-location, if it's feasible in your centre to have those co-located clinics. There's a lot of corridor conversations and rapid referrals and things that can take place where patients get their needs addressed in a one-stop shop. I think having processes in place so that high-risk patients are identified and have nutrition intervention early, so your screening and blanket referral processes. And then around practices, making sure that we have evidence-based models of care, using evidence-based tools. They're the three key things, I think: structure, processes, and practice. And probably the last thing I would throw in is those intangible things about culture. The leadership, both dietetics and within the MDT, is inclusive of expertise from a wide range of disciplines. So they're the magic ingredients, but let's see if we can add to that.
Brilliant. I'm going to throw to you next, Reese. Let's hear from you as a speechie. What are your thoughts?
Thanks, Jenelle. I wish I had went first, because Merran went with some absolute bangers from the start. But I think we are very lucky at Peter Mac. We have a system where we can see patients through all facets of care. We see them pre-treatment, during treatment, post-treatment, and we have that luck. We have, as Merran mentioned, co-located clinics which allow us good access. We have joint assessments where we're providing the same information, but we're avoiding duplication because we see them together and we run through the same things. We have the same goals that we work with for them. I suppose for services that I don't work in outside of Peter Mackey's, you've got to work within your limitations. So I think you have to do what works for your health service. And we have an element of that in SpeechPath in terms of how we work, and we target high-risk patients. We target the ones we can make a difference in. And then we implement systems such as screening tools in other services and in other tumour areas that we may not be able to get to. But I think that's the best thing we have is the co-location. I can't fault that. Like Merran says, joint access, we're in the same place, we have the whole team there. We deal with problems on the same day, and the patients don't have to attend multiple appointments over multiple days. So I still think they're probably the best things that we do. Great.
Thanks, Reese. Over to you, Sarah, from a nursing point of view, the pivotal centre really to cancer care. Please please share with us the role of nursing in terms of providing optimal nutrition care.
Well, I guess you kind of hit the nail on the head, because I do think for any model of care to be successful, it has to include specialist nurses. We're the ones that meet the patients first, at diagnosis. So we're, uniquely placed, I guess, to make sure those referrals are timely, early, appropriate. We often know their social situations well, we know their families well, we understand how that can impact on the patient's ability to get through treatment. We know that people who are well supported tend to do better, tend to complete treatment better, whereas people who are not so well supported struggle more, so end up in hospital, costing the health service more dollars. So certainly having specialist nurses around. As a nurse practitioner, I work closely in our clinics with our dietitians and speech pathologists. I'm able to, make sure that patients receive appropriate care, because I can prescribe medications, ensure that the patients are taking their medications appropriately. I'm just reinforcing all the time everything that everybody else in the MDT does. But I guess as nurses, we tend to be more accessible often than other people. All my patients have my contact numbers. They often call me. I tell them to call me. It's easier to call me. I can triage the situation, make sure they get to the right person. So, yeah.
Brilliant. Thanks, Sarah. Tsien, anything you'd like to add from a medical or rad-onc point of view?
I think, everyone's mentioned really great things. The patient education part, I think at the very beginning, is one thing we struggle with. I think we all are on the same page. We're all telling the patient the same thing. And Merran touched on images before, but no matter sometimes how much you tell people how important it is, and even I've tried to put some shock value in actually for patients that lose weight, and then I show them their scans and the fact that their tumour's actually now borderline not being covered anymore because they've lost so much weight with their sarcopenia and their weight loss. And sometimes that even doesn't sink in. So I think if we can somehow get some motivation for patients and an understanding of the importance for all the reasons that nutrition is important. I know the EAT study kind of tried to look at that as well. That would be good. And I think your service, really everyone's a bit different. And Peter Mac, we have all these things that Reese's talked about, but if you pick apart things, then we actually do have a little shortfall at the moment, and that is our ability to access PEGs. So I think you just have to look at your service, which parts potentially are a fall down, and talk to exec and say, look, these are the issues we're having. We're having all these patients, they're losing weight, they need PEGs, but we can't get theatre space, and the GI surgeons can't get in because they're categorised too low in terms of priority, and that needs to change. So they're my thoughts.
Thanks, Tsien. Yeah, key stakeholder engagement is so super important at all levels, isn't it? And Jane, I'm going to give you like 10 seconds to add something really key.
I agree with what everyone else has already said. I guess I would just add that it's really important to have dietitians involved, and I think they play a key role in making decisions regarding feeding tubes. So both, whether it be an advanced practice dietitian in PEG clinic or as part of usual clinical care, I think it's really key that dietitians are providing advice and input regarding type of tube and timing of tube feeding.
Wonderful. And in the interest of time, I am going to pop up a slide again now and before we finish. So thank you to our panel. I am going to run a couple of quick polls, so please don't run away just yet. We would love to know your thoughts about how you found tonight's webinar, and this will help us look at perhaps what is missing from an education point of view, and would help us and the Head and Neck Society also look at what might be needed. I'm just going to give you a moment to complete that poll. All right, last poll's in, thank you. And the last one I'm going to run. So if you can just tell us what you'd love to know more about. Sure if that one's running. Wonderful. I'm going to give you a couple more moments. I should have had some music playing just to keep things going. Thank you. Last responses in. Actually, I'll keep that running. Can I just bring your attention to other ANZ Head and Neck Cancer Society webinars that are on? You can see the link there for the web page to look at any future events, future webinars, highlighting some future events coming up. I'm sure you're aware of the Head and Neck Society ASM coming up in August. To note, COSA, who's a partner of the Society, has their ASM in Melbourne in November of this year. A little relentless plug for a Peter Mac Nutrition Dietitian PD event, which is coming up in September. Please get in touch if you're interested. And in addition to, Merran highlighted some great resources. I really do need to highlight some fantastic resources in the Head and Neck Cancer Australia website as well. A little plug for the Society. If you're not a member, please consider joining. And there's also the Research Foundation attached to the Society as well. So many thanks to, in particular, Merran and Jane as our main speakers tonight. Your expertise and leadership is absolutely paving the way for further innovations in the cancer nutrition space. So thank you. Big thanks to Tsien, Sarah and Reese for joining us on our panel. And of course, to all of you attending live and or watching this recording. Have a great evening. Thank you very much.